Roger McLean presently holds the post of Research Fellow attached to the HEU Center for Health Economics in the Faculty of Social Sciences. He is also a lecturer in the Department of Economics right here at St. Augustine. He has been conducting research and working in the area of development economics in general and health economics specifically for over 15 years. Among the areas covered in his research are the economics around health sector reform, sexual reproductive health issues, focusing on such conditions as cervical cancer and HIV/AIDS throughout the Caribbean region. Mr. McLean will be presenting for us this afternoon an assessment of the financial dependence of the Caribbean's response to HIV. Let's welcome him.
Good afternoon, everyone. Hearing me? Good. Given my role as co-chair of COTE, I'm allowed to speak beyond the allocated time, and so I will pretend to ignore Christine and focus here and not look at the signs. She is obligated to show them, so play along. So my presentation today essentially looks at an assessment of the financial dependency of the Caribbean. And for those of you who are here this morning, you would have heard Dr. Green make reference to this study. It's a study that was commissioned by the Pan-Caribbean Partnership in collaboration with Eddie's team. And it was developed to inform the Caribbean roadmap for HIV. And so the study essentially was commissioned to answer 3 questions. Basically, to what extent is there financial dependency associated with the HIV response, the region's response? If so, what's the extent of this dependency? And coming out of that, what are the suggested recommendations for arresting the problems? By way of methodology, what we sought to do was a cross-sectional analysis, drawing on, to a large extent, secondary data. We compiled data from a number of country program reports using the UNGAS and GAP reports on HIV that countries submit to the international agency. But we also had an opportunity to look at national aid spending assessment reports that were done by a number of these countries. And so that was the basis of the information that we've compiled. Some limitations, of course, inconsistency in terms of the formatting of the tables and the way in which data were presented, incompleteness in terms of the country data, and so that is for those of you who've been doing work in the region in terms of data, that is not necessarily anything new. A quick look at who we are. This is to a large extent for the economists and social science around us, nothing new. We are small, we are open, we are volatile, we are monocrop. The crop has not changed from sugar to where we are now, whether it's oil and gas, whether it's tourism, but it is still monocrop. We are vulnerable. We are vulnerable to external forces, and because of our size, we are external, we are recipients, we are price takers, so to speak. We are vulnerable to natural disasters. I made this speech a few weeks ago, a month and a half ago, and I made reference to, at the time, the natural disaster component, and made reference to the fact that around this time of year, we do a collective inhale and hope that nothing coming off the coast of Africa heads our way. And at the time, I made reference to a particular weather system that we were hoping was not going to head our way. Turns out that it did, and now we have Dominica. We are not homogeneous. Although we are classified as Caribbean, there are significant differences despite our size within the Caribbean countries. But in spite of that, we are experiencing similar situations and similar conditions that the global community do experience. We are going through and continue to go through the demographic transition. Our populations are aging as fast as, and in some cases, faster than a number of the countries in the larger territories. we are treating with and dealing with the epidemiological transition. So we are grappling with the issues of chronic diseases, some of which is a large part of which is linked to the demographic transition. As we are getting older, our profile is changing. Issues of violence, a number of issues that were raised over the last 2 days of the conference are very much upfront and center in our Caribbean epidemiological profile. And that is our reality. We are treating with the same things that a number of other countries are treating with, but we are operating within the confines of who we are as the Caribbean. The reality of our Caribbean economic profile is reflected in the table that you see before you. Post-2008, 2009, we have not really gotten into the swing of things, particularly among the service-producing countries of our region. 2% growth has been the order of the day. Another feature of our profile is our high public debt to GDP ratio. In a number of countries, upwards of 60% of our public debt represents 6% of our GDP, sorry, and in some cases upwards of 100%. So there are clear implications in terms of where we are. Public debt is a major challenge to our development. Our situation, while moderated slightly in 2013, still continues to be a problem, but we are still classified as middle income. And that in some cases is not necessarily working in our favor. This is the classification based on our, 2012, but based on this, we are, a large portion of our countries are classified as either middle income, middle upper, high income. And when you look at it within the context of our Caribbean realities, Dominica is classified as middle upper. Have you seen and been to Dominica? Right. So that's our reality. Looking now at the assessments, particularly as it relates to the study and the requirements of the study, when we look at the spending assessments, and again, remember that we're looking at evaluating the extent to which we are dependent on funding, donor funding. A snapshot of the external funding for antiretroviral therapy for HIV provides a snapshot of where we are. 75 to 100% external funding. We have countries from Guyana to the St. Vincent and the Grenadines. Medium, 20 to 50 to 75%, Anguilla, Cuba, BVI, and so forth. Belize, Bahamas, Trinidad and Tobago, Suriname are classified as no dependence, 0 to 5%. So we still have, in terms of our, if we are to use ART funding as a proxy for the extent to which there is dependency, it is clear that, and this is a frightening statistic because they're showing that countries are still, to a large extent, dependent on their funding for antiretroviral therapy. Upwards of 75% of the countries, 75 to 100% of your funding is external. When we look at it specifically to our spending assessments, and again, more specifically to countries, and we look at spending by public, private, and external sources, we see that of these countries here, 3, 6, 9, 12, or upwards of 12 countries, we have more than half of them are experiencing external funding upwards of 50%. So Barbados, the big ones that jump out at us are, of course, Haiti with 99% external funding, Barbados 66%. These things will vary, but in and out of your funding stream, Jamaica 73%, etc. On average, upwards of 56% of the funding is external. When we look at HIV spending by programmatic areas, the black bars here for countries such as Barbados and Haiti represent care and treatment. Now look at that within the context of the tables that went before that said that these are countries, particularly Haiti, where you have a large percentage of your funding dependent on external support. So you have this large bar that is to a large extent dependent on external support. A closer look at HIV expenditure provides a bit more insight. So what we did was look at expenditure. The figures on your right, the last column, gives you the dollar value HIV spending in US dollars. But when we look at it within the context of HIV spending per capita and HIV spending per person living with HIV and AIDS, we see a bit of a difference. These are numbers. These are large. These are your dollar values. Per capita, your top 4 countries: Barbados, Haiti, Belize, St. Vincent, and the Grenadines, in that order. When you look at it, HIV spending per person who are living with HIV, Haiti falls out of the top 4. So in spite of the fact that Haiti, the country that continues to be carrying the heaviest burden of HIV, when you look at the HIV spending per person who is HIV positive, the figures are not necessarily reflective of where the burden in fact resides. When we look at HIV expenditure, HIV spending, as a percentage of GDP and as a percentage of total health expenditure, what we call THE here, a very interesting picture emerges. On average, HIV spending as a percentage of GDP is with Haiti, on average, overall, 0.385%. But when you look at individual countries, HIV spending as a percentage of GDP, with the exception of Haiti, just under 3%, most countries are spending less than 0.3% of their GDP. So if you take Haiti out of the average, the average without Haiti, HIV spending as a percentage of GDP falls to 0.129, 0.13%. When you look at HIV spending as a percentage of total health expenditure, on average, again, we're looking at 3.48%, but when you look at Haiti, that stands at 20% of total health expenditure, HIV stands out, compared to 4.5, 2.9, and below 1% in a number of countries. The average without Haiti falls to 1.78%.
4 minutes.
I can look at you now. How much time? 4. Thank you. I had to do that. We're looking at the per capita spending on the basis of HIV spending per capita, and we again looking at 2 countries we're looking at. Remember from the previous table, Barbados was one of the top 4 when we looked at HIV spending per capita. Haiti again within the top 4 as a per capita. But then look at the difference. It's a clear distinction between the 2. Where you have a just over $25 per capita and 20 in Haiti, we are talking about a total health expenditure per capita in Barbados of $1,449 versus a total health expenditure per capita in Haiti of just over $100. So we're talking about 20 out of the $100 spending on health, on HIV, versus 25 out of $1,500. 20% versus 1.7%. Further, when we look at the countries on a comparative basis per capita GDP, we are talking about a country that is demanding more of their HIV spending out of their total health expenditure on a per capita GDP of just around $700 US. So, what are your summary points? Is there a dependent issue? Are there still issues of high levels of dependence? Yes. What are those causal factors? Well, intrinsic and extrinsic, the internal dynamic that exists in these countries are a key factor, the bottlenecks, the high public debt ratio, etc. There are certain extrinsic factors that the opportunities that provided the international response, and they stepped up. Unfortunately, there wasn't a commensurate stepping up at the national level. And so what you have is a situation where the international community stepped into to what was a gap in some cases, but in a number of instances, as mentioned earlier on, the gap really didn't need that presence. External sources remain and continue to be a key aspect of the region's response. Today we have 3 or so key players: US government, Global Fund, and World Bank to a large extent. And that has dwindled from as much as 12 or 15 external agencies. The funding sources cover a number of key programmatic issues, but as we saw, the HIV spending continued to be, with the exception of Haiti, small portions of our region's wealth. The special circumstances of Haiti must, of course, be noted. So, in going forward, what are some of the things we need to flag? clearly a case for Haiti has to be made. She just said 3 minutes. You said 1? You're not synchronizing? Oh, okay, you said 1 too, okay. All right. As it relates to the rest of the Caribbean, there are some things we need to look at. We need to look at the existing health financing arrangements. We spoke of the issues of minimizing out-of-pocket payments. We need to improve utilization and generation of revenue. We need to make more efficient use of resources at the service delivery points as it relates to how we treat with HIV. The resources are not there in large quantities, and we need to make sure that what we do, how we do things are done more effectively, and that we integrate into existing systems and existing structures. We cannot afford to have parallel systems running side by side. It just does not make sense. We need to strengthen the entities that are charged with making the reach of those programs more cost-effective. And so if you have civil society organizations that will make your programs and your interventions more effective, those things must be done. However, we must strengthen those entities that have positioned themselves to so do. The civil society organizations must therefore be strengthened to more effectively make sense and deliver what is required of them, if they have to be part of this process. Continuing measuring is required because we need to make sure that the resources are allocated in a manner that is feasible. We need to explore more and more the public-private partnership. This is a term that is now the new buzzword in the local and regional and international landscape. Public-private partnership does not mean public sector going to private sector for help. That is participation by pocket. And that's what we do. We go to them every International World AIDS Day to get funding for jerseys, for a campaign, and all these kinds of things. That is not public-private partnership. That is begging for money. Partnership, the private sector could be participating by and collaborating by way of their input and by their participation. It is participation in the real sense of the word. We need to move away from that. As we move towards sustainability and the issue of ensuring that what we do in the response program is rooted, we need to recognize the importance of addressing the issues of social determinants, a key issue that was raised here throughout the theme of the conference. Adherence to meds, accessing treatment, testing, raised the critical issue of the labs, treating with new infections, and issues of stigma and discrimination. And lastly, it is important as we move forward that strategies on HIV be linked to national health plans and national development and strategic plans. Countries are going into their third iteration of strategic plans for HIV, and they continue to not be linked in any way, form, or fashion to what is happening in the health sector, and even further away from their national strategic plans. Thank you.